Thank you for joining me. My name is Ralph Bradley. Recently, the federal government released the most recent Healthcare Expenditure Account. I will use these results along with other data to discuss how much we as American citizens are getting for our healthcare dollar. This is an important issue. Almost 20% of our economy is based on medical care. And for every dollar spent on personal consumption, 22 cents goes to medical care. Much of what we spend is hidden. We only see the co-pays when we go to the doctor's office or fill a prescription. But most of what we pay for health care is through taxes or through health insurance premiums. And all this is taken out of our wages before our check is deposited. So, we do not pay for medical care directly as we do for our mortgage or utility bill. In 2017, the average family insurance premium was $19,000, and the median household income was $61,000. So these premiums are 31% of income. State Medicaid budgets now are higher than the budgets for higher education. So every extra dollar that goes to medical care is one less dollar that goes to another need, such as education, infrastructure, affordable housing, retirement security, cybersecurity, the list goes on. Regardless, the medical care sector is so massive that if we get health care wrong, we get the entire economy wrong. So this is an important issue. I start this discussion by showing how rapidly medical care spending has risen. Since 1960, the inflation-adjusted medical spending per person has grown over eightfold, while the spending adjusted for inflation for the entire economy per person has grown less than threefold. This rapid growth in healthcare spending has caused widespread concern, as has put great and increasing strain on employee payrolls as well as on state and federal governments. Where does this money go, you may ask? This chart gives the answer. It gives a breakdown of where each dollar goes. The chart on the left is the 1960 allocation, and the chart on the right is the 2017 allocation. Notice that the 1960 chart is 1/8 the size of the 2017 chart, because the per person spending in 1960 is less than 1/8 of the 2017 per person spending. In 1960, over 40 cents for each healthcare dollar spent went to hospital care. In 2017, it went down to 38 cents. Now, while hospital prices have skyrocketed over these 57 years, the share has decreased as more and more procedures, such as orthopedic surgery and cataract surgery, are done in a non-hospital setting. This explains the drop in the share. Healing used to be done in a hospital, but today, much of surgical healing is done at home, where family labor has replaced hospital nursing labor. The share for dental has dropped from 9 cents in 1960 to only 4 cents in 2017. Fewer people are getting the routine dental care that they need. The big increase is in administrative costs. In 1960, for every $1 spent, less than 5 cents went to administrative costs. But it doubled in 2017, where almost every dollar that is spent, 9.1 cents, goes to administrative costs. So these are basically bureaucratic costs. This is the cost of keeping records. This is the cost of HIPAA. And over the past 10 years, healthcare has become extremely bureaucratic. And unfortunately, the increase that we spend in bureaucratic processes has taken away from direct healthcare to patients. I have just shown you where the observable spending goes. However, the federal government cannot and does not measure everything. For instance, what's missing in all of this is all the unpaid compensation. Folks like the hospital volunteers, or the uncompensated care provided by family members, driving one to the doctor, picking up one from the doctor, helping one recover at home after a surgical procedure. All the home care that family provide for their loved elderly ones. Some healthcare items are just not included. Such items include sunscreen, gym memberships, and public water treatments. So even though the current spending measures are quite staggering, they don't reflect all of medical spending. So the question is, with all this money going to medical care, is health improving in the United States? And the answer basically is no, not on average. For the first time in U.S. history, life expectancy has dropped. However, this drop is not covering everyone. Not everyone has the same life expectancy. So while life expectancy for men has dropped slightly, it has stayed constant for women. Like income inequality, there is a great deal of health inequality in the United States.
This visual map portrays this inequality of life expectancy across our nation. It depicts the change in life expectancy by county. The counties in blue have suffered deep drops in life expectancy. The yellow counties have experienced a mild drop. The green have enjoyed a slight increase, while the red have had a strong increase. Notice how these results vary across our country. Remember, the blue counties have experienced the largest drops. Most of the blue is in the Midwest and South, where incomes tend to be lower. But even in this region, there are several counties where life expectancy is strongly increasing. Interestingly, most of Alaska is doing quite well, while most of Hawaii is doing poorly. These are totally different results for our newest states. Also, it's important to note that counties where the opioid crisis is the greatest do not necessarily suffer large drops in life expectancy. Both the Atlantic and Pacific coast have the majority of counties where life expectancy continues to improve. But it's not improving for all counties in these areas. There are counties in both New England and New York where life expectancy is suffering large drops.
Not all the reduction in life expectancy can be attributed to the opioid crisis, as many in the media have claimed. There are other sources of early premature death, so we have to put this in balance. Recently, about 2 weeks ago, there was an article in Barron's, the financial magazine, claiming that the opioid crisis was reducing all the retirement systems in the country because so much money was being spent on treating opioid addiction. It also claimed that 2/3 of all deaths were due to opioid addictions and overdose. But that is entirely not true. So to put this in perspective, I'm going to go over just a few leading causes of premature death. It's not a comprehensive list, but it's just to show you that opioids are not the sole source of this decline in life expectancy. So the first source is something that received a lot of media attention maybe 3 or 4 years ago, and it's the rising obesity rates and the rising rates of type 2 diabetes, which leads to circulatory problems such as heart disease and strokes, as well as kidney disease and blindness. And then another cause of early death is gun violence, and certainly that has had some notoriety in the press. And then there's always suicide, and again suicide rates are also rising at the same time that this opiate addiction crisis and this opiate overdose crisis is also mounting. And then there's a problem that a lot of folks do not have access to good preventive primary care. And it can be because they're either uninsured, but more often after the Affordable Care Act, it's because they can't find a good primary care physician because there is such a shortage of primary care physicians. And then there are accidents. There are occupational accidents, there are auto accidents, and there are also accidents in the household. Another source is pollution. So a lot of people have died early because they were exposed to asbestos. And then I'm going to discuss this further, but there's medical waste and medical error. And this also contributes to early deaths, particularly medical error, the wrong diagnosis, or the wrong procedure to treat a particular condition, or just a medical expenditure that takes place that doesn't do anything but spend money and not heal the patient. And then there's substance abuse. And opiate addiction is a subset of the substance abuse. So there are many different types of substance abuse. There's tobacco. And then there's alcohol. And then generally there are narcotics. And in that narcotics set there are opiates, cocaine, and crystal meth. So opiates are only one out of these various examples that are not comprehensive that can cause early death. Now, recently there was a journal published in the Addiction Journal, and it was the Global Statistics on Alcohol, Tobacco, and Illicit Drug Use, and it gave 2017 a status report. And it looked at the various death rates. And alcohol is 18.4%. Tobacco is 15.2%. While opiate addiction is only 0.35%. So I'm not saying that opiates are not a problem. What I'm saying is that there are other problems as well. And we certainly shouldn't put all our resources into opiate addiction. We have to balance our resources and put some into mental health so that we can prevent suicides and gun violence, and others so that we can reduce cigarette smoking. And we have to look at things as a whole. So one big source of early death is wasteful medical spending. It is medical spending that does not work. It is treating that opioid patient unsuccessfully, where the addiction is not cured, or it is that unnecessary procedure that causes an early death. Why do we have wasteful spending? Well, we have it because providers are not held accountable for unsuccessful outcomes. A provider will get paid the same amount of money whether a procedure works or not. So, for a comparison, let's say I go and I buy a cell phone and that cell phone doesn't work. What do? I can go back to the retailer and I can say to the retailer, give me a cell phone that works or give me my money back. But if a medical procedure does not work, let's say you have surgery on your rotator cuff and the surgeon makes a mistake, that surgeon will still get paid. And if you have to have corrective surgery, that surgeon gets paid twice. Now, there is an exception here. There is a Medicare Part A reimbursement procedure now that does reimburse on outcomes for hospitals, but it is a very superficial approach, and it is administratively, procedurally, and methodologically incorrect. And as an example, I could be a patient coming out of a hospital and I have a a terrible 31 days of morbidity, and I'm in pain, and I die on the 31st day. And then there is that other patient who lives another 40 years, sees his grandchildren, runs triathlons. Those two cases are both considered a successful outcome. And then we have the problem that provider interests are not aligned with patient interests. So providers have an incentive to recommend procedures that are not tested by time, that are expensive, that will make health insurance premiums increase, that will increase expenditure for public health care programs like Medicare and Medicaid, and will cost the taxpayer more money and will cost the patient more money. And then there is the lack of transparency on reimbursements. In the United States, the prices that are negotiated between pharmaceutical companies and between providers are negotiated in secret, so that individuals can never find out what the prices are that various insurers reimburse on various types of procedures. And again, this creates waste because it prevents the patient from comparison shopping. And then we have the lack of competitiveness. Over the past 10 years, there has been a vast consolidation, not only of provider practices, but also of health insurers. And this has led to less choice. And it has also led to an inability to shop on price. Typically with competition, what you're able to do is you have plenty of choices of insurers and providers, and you can look at both their prices and their quality and pick the one that will give you the best quality for the dollar. But you can't do this if both quality and prices are held in secret. And then there is diagnostic error. Providers and hospitals are not docked on their reimbursement for diagnostic error, and this is a horrific problem in our medical care system in the United States. And then there's inadequate record keeping and record coordination. We don't have one central place where we can keep all records. And when we use physicians or hospitals from different firms, they are very inept at sharing records. And a lot of times it means that we have to have duplicative tests again, like duplicative X-rays, MRIs, EKGs, duplicative lab tests, and this takes money out of our healthcare system that we could use either to meet other social needs or to heal patients who do not have access or the adequate funding to meet their own needs. And then sometimes they're just faulty attempts to economize. So, for an example, an insurer might disapprove a patient's knee surgery to get a knee replacement or something like that. And they might save $10,000. But then that patient can't exercise anymore, is immobile, and becomes overweight, and gets heart disease. And at the very end, you might be spending $40,000 on strokes, on diabetes, on open heart surgery. And then there's just fraud and abuse. And one major source of fraud are self-referrals. Typically, one uses a provider or a physician, particularly a primary physician, to get referrals to another specialty. With all the consolidation of physician practices now, what most often happens is that primary care physicians self-refer to specialists in their own practice. And this is typically a great conflict of interest, and it prevents the patient from finding the best specialist to meet his or her needs. And then there are reimbursement incentives to use expensive and unnecessary procedures. This is a major problem. We hear and we see over and over again hospitals and physicians prescribing very expensive drugs, very expensive procedures, when cheaper alternatives can do a better job. And then a key thing is just the lack of access to primary care. There is an artificially created physician shortage that was created by the American Medical Association. And the American Medical Association has created these very high entries, these barriers to entry, so that we have this looming physician shortage, and within the next decade, a third of all physicians are going to turn retirement age. And what this will do is it will create a shortage, drive up prices, and leave many folks who are insured, who have good insurance, without access to a good primary care physician to prevent more expensive diseases. And continuing these problems of lack of access and unnecessary procedures makes life easier and more profitable for both insurers and providers. But at the end of the day, healthcare is such a large portion of our economy that this waste that is induced by the profit incentive of these providers is going to really drain our budget, both at the federal level, at the state level, and at the municipal level.
We all want to protect pre-existing conditions. However, many politicians claim that having an insurance policy that covers pre-existing conditions is all that we need. But this is far from true. We need other things. Patients with pre-existing conditions also need access to providers who will treat them. The current legal system requires medical doctors to get the necessary treatments and to access pharmaceuticals. For example, a patient with diabetes cannot on her own prescribe her own insulin and get access to the lab tests that she needs in order to treat her condition. Also, the patient with depression cannot write her own prescription for an antidepressant or a selective serotonin reuptake medication to treat her depression. And the rheumatoid arthritis patient can't prescribe her own Humira to treat her rheumatoid arthritis. All this has to be done with the approval of an MD who actually writes the script for the pharmaceutical store to provide this medication. Many of those with pre-existing conditions have health plans that already cover pre-existing conditions. But with the current shortage of physicians and nurses, they cannot access their necessary treatments. Their inability to access these providers who have the authority to prescribe the treatments and the pharmaceuticals that will successfully treat their pre-existing conditions will make them sicker. And eventually, treating them becomes more costly than necessary. So, for example, you take your diabetes patient. This diabetes patient cannot get access to primary care to get her insulin and all the treatments that she needs to keep her blood sugar levels at the same level. What happens is she ends up getting heart disease or getting a stroke or getting kidney disease or just becoming blind. And then you have to treat this other illness that results, such as blindness, such as kidney disease. And this makes treating the patient with pre-existing conditions more costly than necessary. This lack of access is very profitable for the providers. While physicians and nurses benefit from the shortage in their professions, patients suffer unnecessarily, and their shortage adds to wasteful spending. What happens is this shortage allows physicians and other providers to demand a higher reimbursement. And this makes more costs for the healthcare system. This shortage of physicians and nurses exists because the medical industry is self-regulated, thanks to powerful lobbyists in DC who argue in Congress on their behalf. However, the financial crisis has shown us that self-regulation never works. As I have said, one reason that our healthcare system fails to improve overall health is that providers and pharmaceutical companies profit from both a lack of accountability and from the wasteful spending. There are powerful and well-financed lobbyists who convince Congress yearly not to improve the system where sick patients would have the same protections from fraud and faulty treatments that a smartphone buyer would have. These lobbyists spend heavily in political campaigns so that politicians are held beholden to them. Here in this slide, I show you the top recipients of healthcare lobby campaign money in the 2018 congressional elections. As you can quickly see, both sides, the Republican and Democrat, get this money. It is a bipartisan pathology. I give one example. In 2018, there was a highly contested senatorial race in Texas. It was the most expensive Senate campaign in U.S. history. In red, I show the healthcare campaign receipts from both the Cruz, the Republican candidate, and the contributions to O'Rourke, the Democratic candidate. The healthcare industry financed both sides of this race. As a result of this influence, neither Cruz nor O'Rourke talked about aligning provider interest with patient interest. Neither candidate called for provider accountability and less bureaucracy. Neither candidate called for the end of medical waste and medical fraud that creates massive profits for the healthcare industry. Neither candidate opposed the successful efforts by the American Medical Association to limit access to retail medical clinics that give consumers more time flexibility and more choice and save costs at the same time. Both Mr. Cruz and Mr. O'Rourke were held beholden to the healthcare industry. In the end, Texan voters, as well as the American taxpayers, healthcare policyholders, and patients lost out. As I have said, we need to get healthcare right if we're going to get this economy right. This means that we as American citizens must use our voting power not to support any candidate who gets campaign contributions from the healthcare industry. We need lawmakers who will fight for patients, taxpayers, and health insurance policyholders, and not for the healthcare industry.
This ends our presentation. I want to thank Kool-Aid Mahi for making this possible. And also I want to thank all the federal fiscal agencies for providing me with the valuable data that I used in this presentation. Day by day, we have many dedicated employees in various federal fiscal agencies who are providing you, the public, the essential data that you need to make both good decisions and good, sound policy opinions. There is currently a raging debate. Should we have a mixed private-public system as we currently have, or should we go to a completely public system like a Medicare for all system? But if we continue to not hold providers accountable not provide consumer choice, not eliminate wasteful spending, and not have full price transparency, no system will succeed. A private system won't succeed. A public system will not succeed. Standing up to powerful medical institutions and powerful lobbyists like the American Pharmaceutical Association, the American Hospital Association, the American Medical Association is a daunting task. But in order for our economy to survive in the next couple of decades as baby boomers continue to age and get sicker and sicker, we have to eliminate the wasteful healthcare spending. We have to align provider interests with patient interests. We have to align pharmaceutical interests with patient interests. And we have got to end the price discrimination currently allowed for pharmaceutical companies. Many will deem this as hopeless. After all, these institutions have lots of money and lots of influence, as I have shown. They finance all kinds of campaigns, and too many of our elected representatives are held captive by them. But it can be done. And I will give you a couple of examples where this has been done in the past. One example is with women's reproductive health. 20 and 30 years ago, there were numerous hysterectomies, numerous C-sections that were done that were unnecessary because these procedures were very profitable for providers. And when awareness came that these were wasteful procedures, and not only wasteful, but something such as a hysterectomy ends a woman's ability to produce a child. And so there was an effort that took place, that took outreach, that took education, that took passion, that took determination. And in the end, from 2003 to 2010, there was a 36% reduction in the number of hysterectomies. And this effort is something that can be replicated across all procedures and across all conditions. Presently, we have two bipartisan efforts afloat. One effort is to make insurance, reimbursement, and prices more transparent. And there has been progress made on this front. And insurers have been put on notice. And another one is the notoriety behind the price discrimination that has been practiced by pharmaceutical companies. Again, there is a bipartisan effort to stop this. So we can succeed. And we must succeed in order for our economy to survive and for the millennial and the Generation Z generation to have some hope. It is time to get to work. Thank you for joining me.